Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Niba Sayed. I am Assistant Professor of Endocrinology at Allama Iqbal Medical College in Lahore. I'm also the Vice President, Punjab from Pakistan Endocrine Society, and I welcome you all on behalf of Pakistan Endocrine Society on this thyroid webinar, which actually is really, really important. But before I start with the session, before I introduce my worthy panels and speaker, we will start with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين
Ameen. This will be followed by the national anthem. So a very enthusiastic beginning, I must say. And when we look at thyroid and thyroid disorder prevalence in our society, we have quite a few papers and articles that tell us that we have almost 4.1% prevalence of hypothyroidism in our society and roughly about 5.1% in of hyperthyroidism. And this is the prevalence of the patients who have actually been diagnosed. And then there are those patients who are not being diagnosed. But then this is one aspect. There's another aspect that do we actually know how to approach the thyroid dysfunction? This is a big question mark, and we in our practice have seen so many times that there is some there is a need that we learn direct from the masters who actually know how to deal with the thyroids. And we Pakistan Endocrine Society have requested, and I'm really thankful to all my panelists and speakers who have actually agreed to join us, who have agreed to impart their knowledge to us, especially the Sunday morning. Firstly, I'm really thankful to all of you. And then I'll take this opportunity to introduce my panel of experts that include Professor Najmul Islam. He's a name well known. He's a consultant endocrinologist at the Aga Khan University, Karachi, and also the founding member and the past president of Pakistan Endocrine Society. Sir, I'm very thankful on behalf of Pakistan Endocrine Society. I also welcome Professor Ali Java. He's consultant endocrinologist. He's also the medical director of Wilcare, Lahore. He is the past president of Pakistan Endocrine Society. Professor Ali Java, I'm really thankful that you joined us today. It's my honor to introduce Professor Zaman Sheikh, consultant endocrinologist, Sir Syed Institute of Diabetes and Endocrinology in Karachi. He is also the founder member and of the Pakistan Endocrine Society. So thank you so much for joining us.
Welcome.
Now I take this opportunity and it's my honor to introduce our first speaker, who is Professor Saeed Meher. Anybody who is in endocrinology just know this name. Very pleasant personality to talk to and very, very helpful, I must say. On the personal level, I must say this. So thank you so much. He's a consultant endocrinologist at NICVD Karachi. He's the past president of Pakistan Endocrine Society. And I cannot think of any person better than him who can actually teach us the approach to hyperthyroidism. Sir, thank you so very much for joining us. Thank you so much for taking out time. And now the webinar podium is for you.
Thank you, Dr. Niba, for your kind introduction. I'll try to share my screen. I hope it's visible to everybody.
Yes.
Yes, it is
Yes,
visible.
sir, it is visible.
Okay, so I was asked to talk on the approach for the hyperthyroidism. So whenever we see patient that has got hyperthyroidism, so the all patients with hyperthyroidism has got a different etiology. So when we look at the patient for hyperthyroidism, we must keep in mind that what is the cause behind the hyperthyroidism. That will really help us out in managing the patient properly. So without any delay, I will have some cases which we do see in our clinical practice that will really give you a clear approach how to deal with these patients. Now there are the terms what we call as the overactivity of the thyroid gland that's leading to the excessive synthesis of thyroid hormone and accelerated metabolism in the peripheral tissue. This is the hyperthyroidism. Now, what could be the causes? The most common cause is actually the Graves' disease, which is diffuse toxic goiter, then actually the toxic multinodular goiter, subacute thyroiditis, toxic single adenoma, pituitary tumors, which secretes excess TSH, then molar pregnancy, that's the choriocarcinoma, metastatic thyroid cancer, struma aura, thyrotoxicosis fasciata, maybe sometimes due to the drugs or the uh, taking of the thyroxine for some other reasons not advised by some of the physicians or consultants. So they are some of the common reasons for the hyperthyroidism. These upper four, which I have just uh, again eliminated, are the most common. Mainly, I will say 90% of the cases, or more than 90% of the cases of hyperthyroidism, actually belong to these four categories. Now, starting with the first case, this is a 32-year-old medical doctor presented with 1 year history of weight loss, 7 kgs, palpitations, heat intolerance, and tremor, scanty but regular periods, and height is 160 centimeters, weight is 47 kg, BMI is 18.3 kg per meter square. The BP is normal. She's tachycardic with the pulse rate of 100 beats per minute. She's got bilateral proptosis, which is more on the right side than on the left side with the lead lag. Thyroid is grade 2 diffuse. Bruit was positive. Tremors in the both the hands, which were moist and firm. Lab data shows the FT4 of 3.3, TSH is suppressed. Thyroid antibodies are positive. So this is a very typical scenario in which we do commonly see that patients come to us with these scenarios. So most common thing which we ask ourselves that or our colleagues that what is the diagnosis and what should be the treatment plan. So the common questions which come in our mind that this is most probably seen that this is actually the Graves' disease because antibodies are positive and thyroid is uniformly enlarged and the eye signs are present. So this is the Graves' disease. Now, the second question arises which drug should be used in this patient, PTU or carbimazole. So this is something which we need answers. And the second, how long that drug should be used, and what are the chances of remission in these patients. If you look at the scan, now on your left side is a normal thyroid scan. On the right side, this is the Graves' disease, in which there is increased activity or the gland is really lit up, both the lobes, but uniformly don't have got any nodules. So this is a classical scan of the Graves' disease. Another case is the 40-year-old lady with 10-year history of non-toxic multinodular goiter presented to the gynecology clinic with irregular periods, anxiety, palpitations, fatigue, and weight loss. BMI is 29, pressures 126 by 60. She's tachycardic with a pulse of 126 beats per minute, afebrile. Thyroid is grade 2 multinodular goiter, no bruit, no proptosis, mild lid lag. She has got fine tremors, moist and warm palms. Lab data again, hyperthyroid, free T4 of 2.19, TSH is 0.019. Antibodies are negative. Technetium scan that shows two hot nodules with poor uptake in the rest of the glands. So usually it's a clear cut diagnosis that this is the toxic multinodular toxic goiter, which is very obvious on the thyroid scan, and the again the lab data shows a clear hyperthyroidism in this patient. The classical uh, advice to these patients usually is that we treat them initially with the anti-thyroid drugs, and once they are euthyroid, then usually the treatment of choice in these patients is radioiodine ablation. But nowadays, if the patient don't agree for the radioiodine ablation, then on a maintenance dose for a long time, these patients may be kept. But the ideal or a better approach is the radioiodine ablation in these patients. A toxic multinodular goiter is the most common hyperthyroidism, 20% of the cases. Elderly individuals, more common. Usually that happens in the long-standing goiters, lumpy, bumpy thyroid gland, milder manifestations, mild elevations of ET4 and FT3. It progresses slowly over time. Clinically, multiple form nodules are present when we palpate the thyroid, and the, as I said, shown the told you earlier that the scintigraphy shows hot and normal areas. So this is a classical picture on a scan that shows you the hot nodules and the where the uptake is different in the different areas of the thyroid, and clearly shows that this is the actually the toxic multinodular goiter. This is what the on a biopsy, or when it is being taken by the surgeon, then it really shows on a gloss that this is a toxic multinodular goiter of the thyroid. This is again a scan that shows a large single adenoma, due to which actually the other side of the thyroid gland is being suppressed, and this is again a classic single toxic adenoma of the thyroid. This is a classic picture that is being marked. That is a single toxic adenoma of the thyroid, which the rest of the thyroid gland is not lit up. Another case, this is a 28-year-old, they presented with the fever, neck pain, palpitations, heat and roll, and fatigue. Weight is 50 kg, pulse 120 by 70 BP. Sorry, the pulse is tachycardic 120 beats per minute. She, yeah, is again she's febrile with the temperature of 101 degrees Fahrenheit. Grade 2 goiter, diffuse, tender on the touch, moves with the swallowing, no eye signs, mild tremors of the both ends. Lab data again hyperthyroid, free T4 of 2.4, TSH is 0.03. Again, important thing, ESR is 100 per hour. So two important clues in this case, that she's got the fever, number one. The thyroid is tender on the examination. She has got the ESR is of 100, antibodies are negative. So this is a classical case of the the thyroiditis, and in which usually the treatment of choice in these patients is usually the steroids, NSAIDs, and the steroids in these patients, that depends on the your judgment, but usually the steroids will help it out to resolve the cases the quickly in these patients. Now, subacute thyroiditis is the common hyperthyroidism, 15% of the cases. As I said earlier, it's the immune destruction of thyroid due to the viral infection. Usually, the patients give you history that they have got sore throat, for example, flu-like symptoms, maybe 3 4 weeks back, and then they started having the thyroid swelling or the pain in the neck, fever, which is not resolved, which is usually not very high grade, 100 fever. When they take Panadol or the other things, then it will relieve, but again it will come back. So another point, as I said earlier, thyroid gland is painful and tender on palpation, and the scintigraphy, there is no uptake in the gland. This is again a very important clue that when you are not sure about it, that whether sometime we are not sure about it clinically or the eye signs are absent, then it will be difficult to clinically say that this is a Graves or this is a subacute thyroiditis. If the patient don't have got the tenderness in the thyroid, then usually the thyroid scan will differentiate between the two. In the hyperthyroidism of Graves disease, the uptake is high, but in the hyperthyroidism of the thyroiditis, usually there is no uptake in the gland. And usually, as I said earlier, the treatment is NSAIDs in the corticosteroids in this patient. Now, this is the classical scan which you can see there is no uptake in the thyroid bed, and this is a classical scintigraphic picture of thyroiditis. Yeah, this is the normal thyroid, in which you can appreciate the two lobes, fented two lobes. But if you look at this, there are no uptake in the thyroid gland. But if you look the above, there's uptake in the salivary gland. So this is not thyroid. So this is something which is subacute thyroiditis in these patients. Now again, 24-year-old female gravida, she has got pregnancy and presented with the nausea and vomiting of 2 weeks duration. She has recently lost 5 kgs in the weight. BP 100/65 pulse. She's tachycardic with 120 beats per minute, excessive sweating, tremors, small diffuse goiter, grade 1 goiter, no bruit, no ophthalmopathy, lab data, again hyperthyroid. TSH is less than 0.04, T4 is 14, and antibodies are negative. So this is a few clues in this case that she is pregnant, and in the first trimester usually has got excessive vomiting, and she presented with the hyperthyroid like symptoms. So what could be the diagnosis? Yes, perfectly right. This is actually the gestational HCG-induced thyrotoxicosis, which is not uncommon in the first trimester of the pregnancy in these patients. So usually the what is the treatment in these patients? Usually the treatment is not actually the PTU or the RAI or cardiovascular surgery. Usually these patients needs hydration, the reassurance, and sometimes if they are tachycardic, then a small doses of propranolol will keep them quiet, and they really will help them in these out. And usually it resolve. If the HCG induced thyrotoxicosis, it usually resolve within after the first trimester, and slowly and gradually the lab will come back to the normal levels. So this is something which we do see commonly when the patients from the gynae colleagues are being referred for the advice on this hyperthyroidism state in these patients. The another case, which is again something, the recently 25-year-old lady who recently gave birth to a healthy baby 3 months ago and taken a 6 months maternity leave from her job. The patient intends to continue nursing her baby until she returns to work. She has got no history of the thyroid disease. Again, the pulse is 94, BP is 90/70. Thyroid gland is slightly enlarged but non-tender. PT4 is 3.1. TSH is suppressed. So what could be the options? The treatment options in these cases. For example, first we keep in mind what could be the diagnosis. So carbimazole, PTU, propranolol, prednisolone. So most commonly, yes, absolutely right. You have given the right answer that this is the postpartum thyroiditis in these patients. And again, these patients usually don't need the anti-thyroid therapy, and the beta blocker is enough to manage these patients. So this is postpartum thyroiditis. You can see 3 months after the delivery of the baby, and these patients also present like that. And again, the management is only the beta blockers in these patients. Now, this is something which is quite interesting, and something which is maybe a little bit more from the our junior colleagues. These, they may not see it very frequently, when usually someone elderly would come, the middle age, come with the fluctuating testosterone level, sexual weakness, feeling of fear, has got the normal sense of smell, no weight loss, no or gain recently. Pressures 125/80, pulse is 100, weight gain, weight is 62.7. Uh, Lack of facial hair, thyroid null palpable, no gynecomastia, axillary hair stage 2, 3, genital exam, phallus is normal, pubic hair stage 4, scrotum is small for it, test is right 6 ml, left 8 ml, the labs prolactin is 6.5, LH is 0.32, FSH is 2.8, testosterone is 21. With the lab level, you can see it's pretty high. Fasting sugars are normal. Free T4 is 2.8, TSH is 6.4, and the ACTH is not detected, and cortisol is zero point 0.4. So one thing, just a clue to the junior colleagues, that there is something which you can see, that there is something happening with the pituitary, when actually the TSH is actually not very high, but actually the free T4 is high, but the TSH is not so much rising in these patients, and again the testosterone levels are again fluctuating in these patients. So which of the following is the most appropriate diagnosis? If you are right that this is the TSH producing pituitary adenoma. Now in these adenomas, another clue which I will give you more, that usually these patients, they've got the, if you look at that patient, the TSH is 6.4, which is not suppressed, but the FT4 is again high, which is 2.9. Usually what happens then, when FT4 is high, the TSH got suppressed. In this case, the free T4 is high, TSH is again not suppressed, and that gives you a clue there is something wrong in the pituitary. So this is usually a pituitary producing pituitary adenoma, and these are the cases which we do see, but they are not very common. But I put this case deliberately, that when you see TSH is not suppressed, free T4 is high, then you think about the pituitary causes and look accordingly, or refer that case to some of the senior colleagues, some of the endocrine colleagues, for the further management and the evolution and the management in these patients. Now another case, a 42-year-old woman come with a tachycardia, massively obese, lost 14.5 kg in the past 3 months. She has got a BP of 145/70, pulse of 120 beats per minute. She has stare but no proptosis. Thyroid is not palpable. Tremors are present, and she has decreased muscle strength. Free T4 is high, 2.9. TSH is suppressed. 24 of radioactive uptake is low. Thyroglobulin is suppressed, zero point 0.5, and then that actually gives you a clue, something which is we sometimes do see. So just what could be the options in this case? Keep in mind the thyroglobulin level is low in this patient, although the free T4 is high, TSH is suppressed. So subacute struma aurea. So this is something which we call thyrotoxicosis fasciata, or exogenous thyrotoxicosis. When someone takes the thyroxine from outside, which are not hypothyroid, to lose weight, then usually the thyroid becomes hyperthyroid, free T4 is high, TH will be suppressed, and usually the distinguishing point is that if you do the thyroglobulin level, usually thyroglobulin level is high, and that gives you a clue that this patient is actually taking the thyroxine from the outside, which is causing this issue, which is thyrotoxicosis fasciata in these patients. Just give you a final few slides. On the upper top is the normal, then second one is actually the Graves' disease, uptake is high, then third one is actually the toxic multinodular, right is actually a single toxic adenoma. So you can distinguish between the different thyroid scans in your patients. I think with this I will thank the Pakistan Endocrine Society for their kind invitation to join or share my this presentation approach with hypothyroidism. Thank you again for all.
So thank you so very much for very, very informative session. And I think you have pretty much दरिया को कूजे में बंद कर दिया, if I would say so. Very, very important points in a very short span of time. I'm really, really thankful. I think the questions we might be able to take at the end, because Dr. Khurshid Khan, who is our second speaker, he's ready with the presentation, his presentation. Let me introduce Professor Dr. Khurshid Khan.
Hello. Assalamualaikum. Can you guys hear me?
Sir, we can see and we can hear you, and I'm so sorry your introduction was because of this technical glitch that might happen somewhere. Sir, over to you.
Thank you, Dr. Niba. So we'll try to cover hypothyroidism in next 25 minutes or so. The topics we are going to cover in hypothyroidism: definition, epidemiology, physiology, symptomatology, different causes, how to evaluate these patients and treat them. So hypothyroidism, primarily, you all know, is deficiency of thyroid hormone. It could be primary from the thyroid, secondary because of pituitary, or tertiary because of hypothalamus. And goiter is another entity sometimes we come across in patients with hypothyroidism. And third entity is a subclinical hypothyroidism. We will discuss that further down the line. So this is a very very old. Even in old times, you can see pictures of the coins in ancient Greek and Roman coins. You can see the goiter there, Buddhist as well. So word hypothyroidism prevalence is about 0.1 to 2%. In certain population, the prevalence can go up to 4.2%. And subclinical hypothyroidism is more prevalent than simple hypothyroidism there, and we will come to those details in coming slides. Hypothyroidism, more than 95% is primary hypothyroidism coming from thyroid gland, and out of this, Hashimoto's thyroiditis, which is the autoimmune thyroiditis, is the most common cause for hypothyroidism and goiter in non-iodine deficient regions. So TSH activity, what actually does, it increases the iodide uptake and transport, stimulates iodination and organification, and stimulates the synthesis of T4 and T3, increases the thyroglobulin levels within the system, and TPO and lysosomal activity also gets stimulated as well. Stimulates the membrane phospholipase C, thyroid cell hypertrophy, and sometimes even goiter can happen with excessive activity of TSH. So serum binding globulins, different globulins which bind thyroid are thyroxine binding globulin, transthyretin, albumin, and lipoprotein. They act as storage and buffer and help maintain the free hormone within the narrow limits for immediate bioavailability. T4, 99.97% is bound to thyroxine binding globulins, TTRs, albumins, and lipoproteins. And T3 is 99.5% bound. So these hormones, the very small fractional amount of these hormones is present in free active form, and most of the rest is bound with proteins. T3 is mostly produced from conversion of T4 to T3. That's how 80% of the T3 is produced. Some of the T3, yes, does come through deiodinase activity in the liver, kidney, and thyroid as well. It does happen. There are placental tissues and many other tissues have deiodinase for that purpose to convert T4 into T3. So what are the major symptoms and signs we see in these patients? Of course, first is the slowing of the metabolic rate. Patients tend to report fatigue, cold intolerance, dyspnea, weight gain, cognitive dysfunction, mental retardation can happen in infant if not treated in a timely fashion. Growth failure can happen in these patients. Accumulation of matrix substance can happen, which can cause dryness of skin, hoarseness, edema, and some other features. Other symptoms are decreased hearing, myalgias, paresthesias, depression, menorrhagia, arthralgia. Pubertal delay is another factor. Infertility is another factor which can happen because of deficiency of this hormone. So these patients can present with any of these symptoms, and or sometimes you just do a random levels and you find out this one particular patient has hypothyroidism and may not be displaying all the signs and symptoms there. Advanced hypothyroidism, obviously, it's very easy to detect because there will be much more clear picture in these kind of patients, hoarseness, hoarse features, fatigue, and so many which I listed in the past slide. So the screening, who should be screened for hypothyroidism? It's recommended against population-based screening. So that should not be done, but screening should be encouraged only in high-risk group because it's not cost-effective to do screening in all groups. So women above 60 years of age, women with a family history of thyroid disease, prior thyroid dysfunctions, any symptoms suggestive of hyper or hypothyroidism, or a patient has abnormal thyroid gland on examination, patients with type 1 diabetes, and anyone with a personal history of autoimmune disorder or even with a family history of autoimmune disorders. Those are the right kind of patients who should be screened, definitely. And then any other patient you suspect there's a possibility of hypothyroidism because inability to lose weight or gaining weight and any other symptoms of hypothyroidism, which I mentioned previously, those patients should be screened for hypothyroidism based on this consensus statement from ATA and ACE and Endocrine Society. So diagnosis, like I said, it is based on labs. Symptoms are non-specific. Indications already went through, so let me not waste more time here. So diagnostic evaluation, TSH is the first line test in this patient. And excellent first line test, 95% of these patients have primary hypothyroidism. So along with TSH, if you suspect a patient could have secondary hypothyroidism or so, you can do the free T4 as well in these patients. So TSH and free T4, primarily, these are the main diagnostic tests which we use in these patients, and they help to distinguish us between the primary and the central causes of hypothyroidism as well, and between the subclinical test as well. There are certain scenarios where we need to do antibodies, especially in subclinical scenario, and we'll come to that when we go there. TSH is usually elevated. Of course, you will expect free T4 either normal or low normal in these patients, or below the normal. Could be any of the spectrum. Thyroid ultrasound is of little value if examination is normal, and scintigraphy absolutely is not needed in these patients. Anti-thyroid antibodies, yes, those can be helpful in patients where patient has subclinical hypothyroidism, and we are thinking about starting with that patient on thyroxine treatment or so. This is a busy slide. Pretty much sums up the same thing, different states. What do you expect TSH and T4 to? For hypothyroid, if you look at the third row, T3 will be low and the TSH will be raised in these patients. So what if someone has low TSH and T4 is low, or even if TSH is in the normal range for the lab, but T4 is low, that certainly is the case for central hypothyroidism. And in these patients with the central hypothyroidism, we want to, before we start them on any replacement therapy with levothyroxine, we want to check their cortisol excess, make sure the cortisol is sufficient before we put those patients on levothyroxine. And of course, anyone with the central hypothyroidism need pituitary imaging to be done. So causes earlier I highlighted Hashimoto's is the most common cause for hypothyroidism. Then there are other kind of conditions which can cause hypothyroidism. Those could be transient, painless thyroiditis, postpartum thyroiditis, subacute thyroiditis, and then iatrogenic is another factor. Could be injury, could be medication induced. We'll come to those medicines which cause that deficiency or excess of iodine. That can lead to hypothyroidism, infectious thyroiditis, infiltrative diseases, central hypothyroidism, and generalized resistance to growth hormone. So these are the common causes which can lead to hypothyroidism. So risk factors. So first talk about Hashimoto's thyroiditis. Risk factor are age, female, a history of goiter, prior thyroiditis, history of autoimmune disease, or family history of autoimmune disease. These patients are Down syndrome, Turner syndrome. These patients are at a high risk for Hashimoto's thyroiditis. So these patients are they have Hashimoto's thyroiditis. They antithyroid antibodies, especially anti-thyroid peroxidase antibodies, they are present in these patients. They tend to have slow onset, gradually over a period of months to years, and with positive antibodies. So antibodies, like earlier I said, they do confirm the clinical diagnosis. They are helpful in putting a specific label on the patient, but considering our social and financial setup of our patients, all patients with hypothyroidism, they do not need to have antibodies if they cannot afford that, because finding antibody in a straightforward case of hypothyroidism is not going to change anything unless patient has different scenarios like subclinical hypothyroidism or so. Radioactive iodine uptake scan and ultrasound, they're really not needed. Like earlier I said, unless you find a goiter, unless there's a nodule in there, then we can talk about ultrasound. And anyone with a hypothyroid, radioactive iodine is not the test to do in those patients, because after ultrasound, if you find a nodule, the next step in hypothyroid patient is to go for biopsy of those nodules if those are indicated based on the ultrasound findings. So what are the different transient? So second cause for hypothyroidism or transient hypothyroidism, which is painless thyroiditis, subacute lymphocytic thyroiditis, postpartum thyroiditis. Incidence is about 8 to 10%, and that needs to be differentiated from Graves. And that's why in postpartum period, be very careful labeling someone as hypo or hyperthyroidism both ways, because sometimes in postpartum thyroiditis, patients can start off with hyperthyroid features, become euthyroid, become hypothyroid, and get back to the euthyroid status. So these patients in the postpartum period, there's no rush to jump and give them treatment immediately. It's worth checking their labs in next 4 to 6 weeks time and see what it is. And then we can have subacute granulomatous thyroiditis, which is called Quervain's thyroiditis. They can present with neck pain, diffuse goiter, fever. And as a matter of fact, anyone presenting with fever of unknown origin and you do not find the source for fever, it's worth doing thyroid profile on that patient as well. So this is a typical the curves there. Initially, these patients are hypothyroid, they become hypothyroid, and then they recover and become euthyroid. Typical triphasic pattern happens in these transient hypothyroid patients. And then there are certain infiltrative diseases. Riedl's fibrous thyroiditis is one of those. Infectious thyroiditis, sarcoidosis, leukemia, hemochromatosis, they can also present with hypothyroidism. Next is, I'm sorry, rushing through slides quickly, trying to finish in time. Iodine deficiency, that's the most common cause of goiter and hypothyroidism in worldwide, especially in the iodine deficient area. So it's aggravated by goitrogenous foods with antithyroid properties. So what are the different foods which can lead to goiters and can have antithyroid effect? Will come to this is a slide which shows you all these cruciferous vegetables, including broccoli, Brussels sprouts, cabbage, cauliflower, kale. All of them, they can be goitrogens and they can have antithyroid effect as well. So very recently, I saw this patient who was using cabbage excessively in an effort to lose weight and stay away from calorie-rich foods. So she was using very excessively, came to me, TSH was around 15 or so. So I took the history. She said, well, I said, what is different you have done recently? She said, well, I've been using a lot of cabbage. in past 3 months or so. I said, why don't you stop cabbage for now, come back in a month time, and let's see how things are. About 6 weeks later, she came back. She was euthyroid. So certainly the foods need to be looked in what kind of foods they are using. Peaches, cassava, not in regular amounts, but excessive amounts of these glycogen foods, they can lead to hypothyroidism as well. Iodine excess, when anytime there's a high iodine, it inhibits the organification. That's the Wolff-Chaikoff effect that protects the normal gland for sudden increase. So sudden increase through iodination inhibition. So high iodine for a long period can cause hypothyroidism in the pre-existing Hashimoto's thyroiditis, and beware of all the excessive iodine which is there in tonics, cough meds, CAP, and topical betadine and radiocontrost. Amiodarone is loaded with iodine. 40% of amiodarone is iodine rich, and it can cause thyroid disease in many ways, and hypothyroidism is one of them. And next is the iatrogenic, of course. A patient that had thyroidectomy or radioactive iodine ablation for Graves' disease or so, that can also cause hypothyroidism through iatrogenic factors. Yeah, this slide is important. Amiodarone is one of the important medications which is used for AFib and ventricular fibrillations. It inhibits the iodination. Hypothyroidism found in about 7% of these patients within 20 months. And mostly these patients have some kind of pre-existing disease. They have either anti-TPO positive, they have some already pre-existing goiter. So these patients are at higher risk for amiodarone-induced hypothyroidism or hyperthyroidism as well. Lithium is the notorious drug which can cause impaired iodine transport and impacts the release of T3 and T4. So it can cause goiter in 50% of the patients and hypothyroidism in about 20% of the patients. Interferons we used to use for hepatitis C treatment, not anymore, thank goodness. So those were also a common source of hypothyroidism as well. So very important to review patients' food habits, review the medications on these patients. And sometimes when you test these patients for hypothyroidism, beware of all medications they're taking. Glucocorticoids, dopamine, dobutamine, they inhibit the TSH secretion. Sometimes for our diabetic patient, I would say that even the metformin, they can impact the levels of TSH. They can cause slightly lower level of TSH with normal T4. So something which needs to be taken in context when people are diabetic patients, they come to you with the TSH of 0.3 or 0.25, very minimal effect, not really significant. Not much of clinical significance, but it's helpful to interpret lab results when you know what medications these patients are using. Anti-epileptics, estrogen, selective estrogen receptor modulators, androgens, and those drugs, they certainly need to be looked at before we prescribe levothyroxine to these patients. Yeah, salicylates, some NSAIDs, furosemide. So it's a whole bunch of medications which can impact that. So important to review those medications. The last line, bottom line, please review medication before starting these patients on treatment. So what kind of treatment? Our goals are improvement of symptoms, normalization of TSH, reduction of goiter, avoid oversupplementation. That's very important because especially in elderly patients, you need to go slow on these patients because oversupplementation can increase the risk for AFib and increase the risk for bone loss in these patients. So all these things are very important when we are setting the treatment goals for our patients. Levothyroxine is the mainstay of treatment. We want to replace the T4, and that treatment is the mainstay and is for lifelong. The synthetic T4, 80% of that T4 is absorbed on empty stomach. That's why we tend to give it 1 hour before breakfast. Half-life of T4 is about 7 days. So it takes about 7 days to have some kind of impact on clinical picture of the patient, on symptoms of the patients once patient starts taking levothyroxine. I mean, there are different formulas there. Hashimoto's thyroiditis, how much levothyroxine you should put that patient on, 1.6 microgram per kg per day. Centrally can go slightly higher. But I would tell you honestly, I have seen, honestly, you need to keep other factors of that patient in mind as well. These formulas are in books approved by different societies, but the reality is, if you have like 60-year patient with ischemic heart disease, I personally would be very hesitant to give that patient 1.6 microgram per kg per day. I would rather start off with a lower and gradually go up. There's no rush that we need to put that patient on a big dose so that we can, on next visit, we can show him, okay, see, we dropped it down all the way even below normal. So that's something we do not want to do. That I would say, looking at your individual patient, you need to decide how much dose you want to start, and then you can always titrate up. But like in previous slide, I said, if you over replace in the very first visit or so, or even later on as well, you risk arrhythmias, bone loss in these patients, tachycardias in these patients. So those are not helpful for your patient. So that's why it's always important to prescribe the dosing of medication, keeping in mind overall health status of your patient, and then of course looking at this formula also. Young patients usually they do fine, but for patients elderly and comorbs, you need to look at the holistic picture and maybe start off slow and then titrate up. Monitoring, how frequently that should be done. Well, once you start these patients on levothyroxine, free T4, you can monitor in a couple of weeks' time and see what T4 is. But usually, the standard practice is to look for what their TSH is, and TSH, the full impact of levothyroxine to stabilize TSH comes usually in 6 weeks' time. So my practice is to bring these patients back in 6 weeks' time with the TSH and free T4 and see how those numbers are, and then adjust the dose accordingly. When these patients on 2-3 visits, they are stable, then I switch them, move them to 3 month, and then if they are stable in 3 month visits, then I move their visit to every 6 month. Yeah, this was for primary hypothyroidism. But remember, for central hypothyroidism, where the pituitary is the root cause, their TSH, measuring TSH is of no value. In those patients, this is the last line in this slide. In those patients, you need to monitor their free T4 rather than TSH with the central hypothyroidism. Yeah, there has been a very long historical debate on as for T3 should be replaced or not. T3 comes in different forms: cytomel, armor, thyroid. But there's literally no data to support that T3 is beneficial for patients, because body, with the deiodination process, body makes its own T3 from T4. So T3 is not really needed in patients based on all the data we have on T3 replacement. Subclinical hypothyroidism. What is subclinical? Patient has TSH, which is raised but normal free T4. It can be as high as 10 to 15 to 20% in women over 60 years of age. So when do we treat subclinical hypothyroidism? Number one, if the TSH is more than 10 on 2 occasions, that's when subclinical should be treated. Anti-TPO antibodies are present, and even with TSH being 6 or 7, it should be treated. Patient has very convincing symptoms. Remember, like earlier slide I said, hypothyroidism patients tend to have vague symptoms. So you really need to make sure that patients complaining of, they are very significant and they are definitely from hypothyroidism, and you give that patient a trial of levothyroxine and symptoms improve significantly, then maybe this is a patient who should be on levothyroxine. Patient has dyslipidemia, very high levels of LDL with subclinical hypothyroidism, they should be treated. Patients who are pregnant, by all means, definitely they need to be treated, because for the first 20 weeks of gestation, the baby is dependent on mother for levothyroxine. So we don't want these mother and child to be hanging in high and dry without levothyroxine. So that's when it's treated. Sometimes infertility is an issue, and in those cases, that's a soft case for treatment. But certainly you can give them trial of levothyroxine during their infertility when they're trying to conceive, for patients with subclinical hypothyroidism. Subclinical hypothyroidism, right? Well, then there are special situations. Patients who's hypothyroid and becomes pregnant, what we do for those patients? We know in pregnancy the requirement for levothyroxine improves by 30% at pregnancy onset in first trimester. So that the levothyroxine dose has to be increased in pregnancy. There are two schools of thought here. Some say, well, you increase their dose to 30% right at the get-go, but others are just see what TSH and T4 is, and then you can do that. My own practice is I tend to look at their thyroid profile before increasing their dose, and I tell all my patients who are hypothyroid, who are in the childbearing ages, if they become pregnant, please get the test done and WhatsApp me, even if they cannot come, so I can adjust the dose. In patients with thyroid carcinoma who are hypothyroid, based on their risk for recurrence, so we tend to have, in patients with the high risk situation, we tend to keep TSH in the suppressed range less than 0.01 and or so, and in a medium range less than 0.1. So your TSH goals are different in patients with history of thyroid carcinomas or so. I think I have taken most of my time. I'm going to just show you 3 slides on mixed edema, just to sensitize the audience about inpatient hypothyroidism is not really a benign condition. People can die from hypothyroidism. So usual symptom mixed edema is when someone has hypothyroidism and has not taken medications for a long period of time, they can present with mixed edema coma. So usual symptoms and signs of hypothyroidism plus hypothermia, hypotension, hypoventilation, paralytic ileus, depressed mental status, and change in mental and coma. So if these features are present in a patient who has hypothyroid, who has deranged TSH is very high, and not taking medication, of course, that's your patient for mixed edema, and there you need to act there and then to save their lives. Giving them IV levothyroxine there in the ER on your first evaluation is a lifesaver for these patients. I'm just trying to. So what can you do for these patients? Oxygen intubation, ventilation if respiratory failure, rapid glucose check, hydrocortisone should be given before you give them IV levothyroxine, because it's just worth covering them with steroids before having them on levothyroxine. Cautious, slow rewarming of these patients. Thyroxine T4, 500 microgram IV, then 50 microgram IV QD should be given to those patients. Is there a role of T3? Well, there's, again, the data is that it did not show any difference between survival in these patients when you gave them T3 or so. But if you gave already T4 patients not responding, it's worth a shot. You can always try that, but there is not any conclusive data supporting survival benefit where you give them leothyronine, which is T3. Careful IV hydration and search for the precipitating cause, always triggered by some factors. I skipped those causes in the back. Purpose was just to highlight you. With this, I thank you all. Thank you, Pakistan Endocrine Society. I thank you, the Board of Management, and my respected panelist here for giving me the opportunity to speak on this very important topic. Thank you.
So thank you so very much for a very detailed lecture. We do have one question that we can take. In the interest of time, I won't be able to take more. Sir, Nadia Fatma has asked the question, if IV thyroxine is not available, then what to do? I think she's asking for mixed edema coma patients.
Yeah, and unfortunately, IV levothyroxine is not available in this part of the world, so it's always challenging. We keep modifying treatment based on what is available. So in those cases, certainly patients, you can use the NG tube modality and give them a higher dose of levothyroxine through oral route, because remember, these patients have paralytic ileus, they already have edema and swelling of the gut, malabsorption is affected. And earlier I said about when you give patients levothyroxine in a healthy patient, 80% of that it gets absorbed. In this patient, you have to assume even if 40% gets absorbed through the enteric route, that's a success there. So you just need to give them a higher dose of oral levothyroxine through the NG tube. That's all you can do. Thank you.
So I think the same question is also asked by Mumtaz Lakho as well, and I think you have answered this question. So thank you so very much. Professor Saeed, there's one question for you as well. Sir, you with us? Professor Saeed, sir, you with us? I think Professor Saeed, are you with us? Sir.
Yes, can you hear me?
Yes, sir, we can hear you. Sir, there's one question for you. Sir, it has been
Yeah.
asked that if there is a, it's if the patient is of hyperthyroidism and pregnant, what can be done to prevent the baby from having the same disease?
Now, the first most important thing is that treat the patient properly right from the day one of the pregnancy. And usually, I will mention here in response to that question that during the first trimester, we usually, the recommendation is from the guidelines that the PTU is given and onwards, the neomacazole is given. Now, the most important thing is that the level should be kept accordingly because the levels in pregnancy are slightly different, challenging, and usually these patients usually are they followed on every monthly basis to adjust their doses of PTU and later on the neomacazole. If your patient whole of the pregnancy remained well maintained, the levels are very well controlled, then there is a chance that this will not happen to the baby. But if the levels are deranged, then definitely the chances of the deranged thyroid function will be more in the baby.
So thank you so much. And I hope this answers the question of the person who asked. We do have, we are just being bombarded with so many questions, but in the interest of time, I think I won't be able to take any more. I would request my panel of experts, starting with Professor Najam, sir, for your comment on the session, for your comment on hypo and hyperthyroidism or whatever your expertise may be.
Thank you, Niba, for inviting me as a panelist in this session on thyroid. Can you hear me?
Sir, absolutely, sir.
Uh, so, I mean, these two talks were very, very, very relevant because these are the two most common thyroid conditions that we come across, the hyperthyroidism and hypothyroidism. And both these speakers have really covered the topic nicely. Uh, as regards to the first talk by Dr. Saeed Meher, uh, he covered this by case scenarios. I just wanted to add one thing that as regards the modality of treatment between the antithyroid drugs and radioactive iodine and surgery, uh, in those who were trained in North America, radioactive iodine is more commonly used there. But those who have been trained in Europe, really, or UK, it is more towards antithyroid drugs. But even in USA, the trend is now changing, and it is now moving towards the antithyroid drugs because antithyroid drugs are pretty safe. The risk of agranulocytosis is high in the first 3 months, and then it tends to go down. So it has to be mutually discussed with your patient, and a mutual agreement has to be made and upon which modality they would like to adopt or go for. So that is something that I would like to add to the talk of Dr. Saeed Meher. And now coming on to talk by Dr. Professor Khurshid. He has covered both hypothyroidism primary and secondary, uh, and he has talked about uh, the the different conditions of hypothyroidism that they come across and the dose adjustment that is required in pregnancy as soon as the pregnancy test is positive is very relevant. And as regards to starting the dose, uh, the formula of 1.6 to 1.7 micrograms per kg is applicable to patients who have got full overt hypothyroidism. But those who have got, say, a TSH of 15, 16, or 20, they are overt by definition, but they don't need the full dose that of 1.6 micrograms per kg per day. You need to take a smaller dose on those patients. And Dr. Professor Khurshid has also highlighted the importance that we need to go slow in patients who are middle aged to elderly and with comorbid condition, particularly ischemic heart disease, because if you give the full dose right away, you may precipitate their angina if they have underlying coronary artery disease. So you need to be careful, particularly in the elderly and those with ischemic heart disease. So these are the relevant things. And one thing I would just like to add to the question that was raised by one of the participants about what can we do to decrease the chances of thyroiditis in the baby. Obviously, monitoring of those who are hyperthyroid, if they are on a small dose, probably the disease will go into remission as soon as the pregnancy occurs and the drug has to be stopped. But there are certain patients who may need to be continued anti-thyroid drugs throughout the pregnancy. But we also measure TRAb antibodies in the last trimester, and if the TRAb antibodies are raised, the neonatologist really have to be very careful because the baby may have thyroid psychosis, so they have to take care of of the baby because of the raised TRAb levels, which may stimulate the thyroid gland of the baby as well. So these are a few comments that I have made really as regards the two talks, and I would like to congratulate both of them for an excellent talk on these two common topics of endocrinology. Thank you, Onibai. Back to you.
So thank you so very much. You have actually answered two other questions that were asked in the chat box, but due to the time restriction, I could not ask. That's great that they got their answers. So thank you so very much. I'll request Professor Zaman Sheikh for his comment as well. Professor Zaman sir, your mic is mute.
Thank you very much, Professor Oniba, for giving me a chance to say a few words. Two excellent talks by two fantastic speakers, Professor Saeed Maher and Professor Khurshid Khan. I have got 2 points to say. Number one, pharmaceutical company. In diabetes, we are forced to do seminar by initiated by pharma company because of obviously commercial reasons. Thyroid drugs are so cheap, almost all the drugs. There are 3 drugs most of the time. PTU, Neomercazole, and Thyroxine, of course. All are very cheap. So there is no interest of pharmaceutical company, which is a major sponsors in our academic sessions. So we have to do from our platform, and I'm happy that this time, 25th May, is celebrated as in form of pre-symposium workshops and this your program. So I feel very happy that this second most common endocrine disorder is getting importance nowadays. Actually, World Diabetes Day started in 1991, but World Thyroid Day, 25th May, started from 2008. Such a latent period before celebrating this thing. But this is a good initiative, and hopefully we will continue this. Second, and even more important, in all the textbooks, in Google Images, we see pictures of myxedema, not hypothyroidism. Myxedema is severe and prolonged the hypothyroidism. 2 conditions, severe and prolonged. So all the pictures we show to students, even in textbooks or Googles, they are myxedema, not of hypothyroidism. And luckily nowadays hypothyroidism is diagnosed much earlier rather than reaching at that stages of severe myxedema. There are 3 stages. Number 1, hypothyroidism, myxedema, and third one is myxedema coma. And myxedema coma is medical emergency. Every hour is important, not day. Every hour is important in the management. So even before getting the treatment, if you have got suspicion, you can start the treatment of myxedema. So these are 2 points, and thank you very much once again. Hello?
Yes, sir, you're audible. Hello? Yes, sir, you're audible.
Yes. Okay, thank you.
So thank you so very much. So thank you for your insights, for your comment. And absolutely, sir, at this time for thyroid, Pakistan Endocrine Society has come up with the webinars, with the institutional programs, CMEs, also the FM radio programs. So we are putting our effort under the guidance of you all, and I hope we can take it forward as well. So thank you so much. Now, may I request Professor Ali Jawa for his comments, please. So sorry, sir, your mic is mute. Dr. Ali.
Sorry about that. Few pointers that I just wanted to share. Very comprehensive talk. TRAB, the thyroid receptor antibody, has a very crucial role, especially if we doctors have access to good quality labs. It helps you differentiate several conditions, such as thyroiditis fructitia, HCG-induced hypothyroidism, as well as other thyroiditis. And if it's positive, that's along with typical symptoms of hyperthyroidism, then it's very certainly Graves' disease. This comes very handy in conditions such as pregnancy and breastfeeding, where you cannot do a thyroid scan. Another condition that somebody had a recent contrast-induced study in which the whole body is flooded with iodine. Thyroid scan is not going to help you differentiate. So that is also where TRAB would be very helpful in differentiating. So that is one thing I wanted to emphasize. If you have access to a good quality lab, TRAB is extremely crucial. As far as hypothyroidism is concerned, the subclinical hypothyroidism is getting more and more attention. Imagine that the hypothyroidism is either it's on the way to become permanent, an overt hypothyroidism, or it's on the way down. It's like a recovery part of the hypothyroidism, and eventually it will become euthyroid. Now that's crucial. That's why we don't rush to treat with full dose of thyroxine. And that's one of the questions that was in the inbox. For subclinical hypothyroidism, how do you start? Depending on the risk factors, age, comorbidities, as well as the level of TSH. If the TSH is barely like 15, the person is 65 and has advanced heart failure, maybe you want to wait a little longer or start with half of 25 micrograms, just for the example. So that's where the art of endocrinology kicks in. It's not just pure science. You have to use your clinical judgment. And anti-TPO antibody helps us in this situation in subclinical hypothyroidism. If somebody has a TSH greater than 4 and less than 11 and 2 different times, that's subclinical hypothyroidism. And an anti-TPO antibody positive does make you strongly consider starting with a low dose of levothyroxine. Other thing is that you remember that subclinical hypothyroidism in pregnancy, we lean towards treating because it's a matter of 2 lives. And if we don't treat it, the harm to the baby is much higher because the first 7 weeks, the baby does not have a thyroid of its own. So it depends on the mother. So if the mother has TSH in the range of subclinical hypothyroidism, we tend to treat the mother. We can always sort it out later, whether it was thyroiditis or was it full-blown hypothyroidism. And other situations in which subclinical hypothyroidism we would like to treat would be like if somebody has already other autoimmune diseases, like somebody has pernicious anemia, somebody has Addison's disease, somebody has type 1 diabetes. And there is also an association with PMOS, polycystic metabolic ovarian syndrome. So Turner syndrome as well as the Down syndrome is something that is important because many times we don't see them. They are seen by the pediatrician. So if we don't sensitize them, there could be a hypothyroidism that doesn't get diagnosed because the apparent mental retardation or slowness could mask the hypothyroidism. So awareness about the hypothyroidism in those patients are important. Thank you again for giving me the opportunity. It has always been a pleasure.
So thank you so very much. And with this, we come to the end of this session. And I always love the pearls in the form of the pointers that you give, and they always work very fine. Sir, thank you so very much. I'm really grateful to our worthy speakers. I'm really thankful on behalf of press to our worthy panelists. Thank you, everyone, for joining. And I'll take the lead from here. Thank you so very much. Allah Hafiz.
Thank you. Allah
Allah
Hafiz. Thank you.
Hafiz.
Allah
Thank
Hafiz.
you.
Allah Hafiz.